So, Dr. Alexa Fiffick is a concierge family practice physician and board certified women's health practitioner in Westlake, Ohio. She has a passion for helping people stay healthy and avoid preventable disorders. So, Dr. Fiffick, thank you so much for joining us today.
Thank you for having me, Amy. How are you today?
Oh, I am good. I'm just excited to talk about our topic. So, for our audience, many of you may not know that osteoporosis can play a role in balance and fall risk, which can worsen dizzy-related symptoms. So, today we are discussing managing bone health. It is not only about preventing fractures, but also about maintaining mobility and independence, which is essential for everyone. So, including those who manage dizziness. So, we are actually going to talk about a topic about medication for osteoporosis. So, osteoporosis treatments can help strengthen bones, but like many medical interventions, there are potential downsides to consider. So, let's dive in and learn from Dr. Fiffick, an expert who will help us break down what you need to know. So, to start, Dr. Fiffick, can you explain what osteoporosis is and why it is such an important health concern, especially for women?
Yeah, so I think osteoporosis is a little bit misunderstood because we've heard that word a lot. But the actual definition of osteoporosis is that you have porous bone. And that really translates to having a low bone density and deterioration of the microarchitecture, aka all your little structures that are holding your bone together are starting to weaken. I like to think about it as you're thinking about, the roads in Greater Cleveland breaking down with potholes when there's lots of ice and a lot of salt use. That once really nice, smooth, really strong road is no longer that strong, and we'll start to see cracks. And the problem with that is that those sort of breakdown, things that are happening towards osteoporosis lead to an increased risk of fracture, which in the dizzy world is a very big concern. And the problem with osteoporosis is that it exists on a spectrum, right? So it's not that as soon as you have osteoporosis, like we're worried. We're worried as you start declining from a normal healthy bone down to the middle kind of part where we start seeing breakdown called osteopenia. And then when we get all the way to osteoporosis, and then there's further deficits beyond just being osteoporotic, and you can end up with something called severe osteoporosis also. One of which the concerns you asked was, why is it such a big concern specifically for women? Unfortunately, we reach our peak bone mass at around 30-ish years old and start having a major, major decline in bone health, even in perimenopause. So the average age of menopause in the United States and Canada is about 51, 52 years old. So those years, even prior to losing your period and losing your estrogen, we're seeing a steep decline in bone mass. So by the time that people become menopausal, they're already potentially having significant bone loss and being at a deficit even before they're 60 years old. So we end up spending 30, 40 years of our life potentially with really weak bones and potentially being at risk of fractures and other really severe side effects from that.
So that's quite a spectrum of age. So starting at 30, we can lose some of our bone mass. So are you having those conversations at what age? And then I guess at what age are we screening and testing for osteopenia and osteoporosis?
Yeah, so the traditional guidelines are screened by age 65. So anyone born female will get a screening by age, I'm sorry, 65. Um, However, there's a lot of things that play into that. And so I usually start having these conversations as early as I can, and trying to get my patients who are even in their 20s and early 30s to really work on building and maintaining bone as much as possible. So I honestly start screening for things that are going to put a woman at risk, put a patient at risk, because I screen my men also. As early as their 20s and 30s, and have most of my patients screened with a bone scan within their first couple years of being into their 50s, typically. Are there patients that I've done that earlier because they have higher risk factors? Absolutely. Almost nobody, in my opinion, should be waiting until age 65, because as you are losing that bone through the course of your 40s and 50s, I'm going to be behind the eight ball if I wait that long.
Yeah, so physicians, it sounds like we should be having discussions with our clients way earlier than 65 when we're actually doing the testing. So thank you for that.
Absolutely.
I think that's a really important discussion to have. Before we jump into medications, with your 30-year-olds, 40-year-olds, is there anything that you can speak to that you are advising or doing for those patients before we reach 65?
Yeah, so one of the biggest things at that age is making sure that you're getting consistent calcium and vitamin D intake and doing weight bearing exercises. There has been a nice kind of uptick recently in seeing recommendations for women to lift heavy things and to do strenuous activities for their exercise instead of like when you and I were young, where it was like cardio, 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 which is great for your heart, but for bone strength, muscle strength, your ability to maintain balance, those things come from having your body challenged with weight and challenged with different positional changes. And so I really strongly advocate for patients to get weightlifting of some kind or mixed mobility exercises in their 20s and 30s and really working on to get a good amount of vitamin D and a good amount of calcium regularly. Um, those are going to be your bread and butter things to build and then maintain your bone.
Okay, so of course, if people aren't already getting that assessed by their physician, ask for a blood draw to check your calcium and vitamin D, and then speak to their physician about what to do about that. Correct?
Yeah, so vitamin D specifically, we can get on a blood draw.
Yeah.
Calcium, your body does a really good job of making sure that your calcium floats around in your blood. One of the ways it does that is by leaching it from places like your bone if it really needs it. So there is a nice calculator that I can show you guys later on the amount of calcium you need to kind of get in a day and how to measure what you're getting. And realistically, we want calcium from food. Vitamin D is super difficult to get from food without really specific diet guidelines. And so that one I'm okay kind of phoning in with a supplement. But
Okay.
as far as calcium, ideally coming from diet, and we can talk about that more.
Okay, perfect. And it sounds like find yourself a great physical therapist or trainer who understands osteoporosis and weight bearing because I see a lot of people trying to do, I'm older, so I'm going to lift 2 and 5 pound weights, and that should be sufficient. And it's just part of, my philosophy to educate people as to, nope, the research is indicating, lift heavier. Even despite your age, try to lift heavier, but you might need a professional to help you do that to navigate, maybe your impairments. So,
Yeah. I'd
uh,
also like to throw out there, sorry to interrupt, Amy,
no.
that because a lot of women that are in Gen X and the boomer generations were not educated at all on weightlifting, it really is important to not go from like 0 to 60. That's a really good way to injure yourself. Which is why it's super crucial to find a physical therapist or a personal trainer. Some people can act as both. Not everybody can, so be careful there. But a good physical therapist can show you how to actually do the moves so you're not injuring yourself and how to gradually increase in weight instead of you just kind of winging it at the gym. So my recommendation would be if this is completely new to you, find somebody who can
Mhm.
help.
So let's get into talking about common medications prescribed for osteoporosis.
Yeah, so probably the first one that everybody is going to think of is an old tried and true called Fosamax. Does that ring a bell for you, Amy? Yeah.
Oh yeah. Mhm.
Um, it probably rings a bell for most people that are even going to bother listening to this conversation. And it's a good medication. So the different medications that we have for osteoporosis treatment kind of fall into two categories. One of which is what we call the anti-resorptives, and one of which is what we call like the bone builders or the anabolics. The things that people think of most often are in that category of the ones that keep us from absorbing bone. And so what I'd like to talk about for people is the difference between what your bone is doing, because this is a little confusing, right? So on an everyday basis for your entire life, you have cells that are building up your bone and you have cells that are breaking down your bone. Those are always happening at the same time. And over the course of 7 years, you will completely turn over your entire skeleton if your bone is doing what it's supposed to. Once women lose their estrogen in menopause and leading into menopause, that breakdown is starting to happen more aggressively than our ability to build up. So that breakdown is what we call resorption. The medications like Fosamax, Reclast, some of those ones that you have heard of before, old school Boniva, and those medications, those keep it from breaking down more than it's able to build up. And so we see more of a steadiness in the bone after using those for a period of time. The anti-resorptives are kind of the first line in most cases. And so that is part of why people are the most familiar with it. As an aside, one of the things that people don't realize is that estrogen falls into the category of anti-resorptives. Estrogen, after you have lost it, if we give it back to you, starts acting the way Boniva and Prolia and Fosamax work in order to help prevent further breakdown and kind of stabilize that. The benefit of doing that is that we're preventing fractures with any of those medications. Now, if you end up in a scenario where you broke a hip, you've broke your back, you have really severe osteoporosis, that category of medications is never going to be enough for you. And that's where we go into the group of medications called the anabolics. That's where you hear words like Evenity, Timlos, abiraterone, really big words that are mainly injectables that you are supposed to give yourself at home because they actually help your bone build up instead of just not break down. And that's the two main categories. I don't want to get too far into the woods without any other questions.
No, no, that's fine. Go back to estrogen really quickly because I think people would be interested. What age group is receiving this to prevent our bone
Loss.
breakdown?
Yeah. So actually, there's really good evidence that being on birth control in your reproductive years, aka like your 20s, 30s, 40s, is going to help maintain that bone, especially once you're pushing towards perimenopause. You're still having a cycle, but otherwise would start to notice some breakdown. That's a really good person to consider doing birth control in to maintain. Once you become menopausal, then we start looking at menopausal dosing of estrogen. And so, depending on when you start that, we could be looking at somebody who's in their 40s, 50s, sometimes 60s to initiate it. And we really see the best benefits after doing a good couple years on the menopausal hormones. So doing something, people think, oh, I can go on Boniva for a year, or I can go on estrogen for a year or 2 years. We really need to get a good, probably 5 to 10 years in there to see benefit for bone, among other things. And using the medications in a strategic way, plus minus some of the other medications if necessary in those sort of menopausal age groups.
Okay, good. So how effective are these medications? Do some options stand out more than others?
Yeah, so I don't always love Fosamax, in all honesty. I find that it is frequently the data behind it being a good anti-resorptive is there. However, from a functional perspective, it's a pill that you have to swallow once weekly. It's a pretty large pill. People tend to forget things you only do once a week, as well as it having a little bit of a side effect of pretty significant GERD or esophageal reflux. That is the number one reason that people quit it. Historically, in my training as a resident, the number one thing that I had patients come back to me having conversations about was I would bring up the fact that they were due for another bone scan and say, hey, well, hopefully it's better because you've been taking the meds. And they're like, you know what, doc? I have to be honest with you. I haven't been taking it. I couldn't tolerate it. I was having such bad GERD that I literally couldn't function. So, from a use perspective, if it's the right person in that category of people who qualify for anti-resorptives, estrogen has so many other benefits that that's where my brain typically goes first, is if she needs bone protection and she would be a candidate for estrogen, estrogen is kind of my standout there. Once we get into the category of patients that have very severe osteoporosis or have fractures, then typically I'm starting to get excited about using something that can help build bone plus minus estrogen in order to help them actually achieve better outcomes. You can see a tiny, tiny bit of increase in a bone density if you use an anti-resorptive. You're pretty much guaranteed to see that if you give somebody a anabolic or a bone builder. So if you need it, that's the right way to go. And I don't like to skimp out on people. And unfortunately, there are a lot of people in that sort of category that would qualify for a bone builder that only end up with like a Foxamax or a Boniva.
Okay. Now, any specific cases where medication are the best and only option? So I've been, with research, it looks like exercise and, nutrition, those are our pillars, and probably along with estrogen, and we don't want to get to medication. But are there any specific cases where medication might be the best option?
Honestly, once we get to the point that somebody's had a fracture, it's not enough to depend on lifestyle things like
Okay.
exercising, diet, and supplements, because they can only do so much and
Hmm.
you're already at a deficit. If you are in a situation in which you are more kind of like on the verge of osteopenia, osteoporosis, or you have a really high risk in the family, or you're having early bone loss in your 40s, but you're still perimenopausal, that's the type of person that really is probably going to get more out of doing the exercise, the strength training, the diet exercise stuff. But as soon as there's a fracture, as soon as you're in that severe osteoporosis category, to me, it's you should be on medication. Now, you can do whatever you want to do, whatever is right for you, but I worry that we're not doing enough for you if we don't offer that medication.
Okay. Now, and just to be clear, if there is a fracture, it could be a traumatic fracture with a diagnosis of osteoporosis, or it could be a spontaneous fracture. Any distinction to make there?
Yeah, so that's kind of the hard part about the different types of fractures. So this is something I try to belabor to my patients a lot. Um, the definition of traumatic means that like anybody would break something if that were to occur to them. So the definition of trauma that a lot of people misinterpret that is actually what we call a fragility fracture
Mhm.
is I was running down the street after my dog and I tripped and I like broke my forearm, or I was trying to slide into a chair and my dress made me slide straight off the chair onto the floor and I broke a hip. If you're falling from a standing height and you're not being hit by a car on the way or like a moped or something like that, chances are you shouldn't have been breaking. Injured, sure, but
Mhm.
actual fractures, not so much. Car accidents, falling off a running horse, that kind of stuff, like those are traumatic. So defining what that fracture's cause is, and as long as it wasn't, hey, I shattered my pelvis because I was in a, T-bone car wreck,
Or fell down a
then
flight of stairs.
yeah,
Or
something crazy
yeah.
that you and I would both break during, then I
Mhm.
got a problem and she's probably got an osteoporotic fracture.
Okay. All right, let's talk about side effects and risks. Any medication that we need to just at least watch for side effects.
Main one probably is Fosamax because it's one of the most commonly used, and that acid reflux
Okay.
can honestly deteriorate the esophagus so much that you can burn an ulcer into it. It can feel like you have a lot of things stuck and cause scarring as well. So being really careful about following the directions if you're on that, and or talking about alternative options if you're starting to see those side effects. Alternatively, a lot of the injectables can come with some bone pain. And I like to talk to my patients about it feeling a lot more like having the flu and it being sort of that all over body ache. Depending on which one of the injectables you're looking at, If it becomes too severe, especially if you're using one of those anabolics where you're stabbing yourself with a needle every single day, every single week, something like that. If it's really not tolerable, go back, talk to your doctor and make sure nothing's wrong. Make sure that we're not doing something else to the bone. There's old data that some of the anti-resorptives can cause something called osteonecrosis of the jaw or like breakdown of the bone in the jaw. Those studies were not necessarily applicable to every single person. A lot of the people in the studies were being studied in the context of them undergoing cancer treatment with chemo. And we use the doses for chemo patients and radiation patients much, much more frequently than we do in patients that have non-cancer health issues and are just going in for osteoporosis, osteopenia treatment. So not so much the worry about that, not so much the worry about that atypical hip fracture thing. Those are kind of really, really rare. But the bone pain, what that means for your day-to-day life, I think are a bigger thing to look out for.
Okay. Yeah, I did see one study, and maybe to your point, you have to look at how the study was done. But that some of the injectables have a risk of bone cancers, like the bone builders.
Yeah.
Is it true? Can you speak to that?
Yeah, I mean, it's technically a real but small risk. It's not a reason I would never put somebody on it. And it really has to be within like a very specific scenario. So if we're helping to build something that is also kind of sporadically growing on its own as cancer does, that is a concern, but it's never been a reason that I've not given it to somebody.
Okay. Yeah, and of course, like you said earlier, just look at the study. You have to you have to know how the study was conducted and who they were looking at.
Yeah.
Okay, so let's talk about maybe some alternative approaches to bone health. And anything else you want to add about medication before we switch to alternative?
I don't think so.
Okay. So any complementary strategies, diet, exercise, supplements, that patients should consider alongside or instead of medication?
Yeah, absolutely. Can I steal the screen for a
I
sec so I
I
can
think
share the visual?
so. Let's see. Yeah. See if we did it.
Let's see if
Perfect.
it is. Can you see this cute little graphic of how to
Yes,
prevent
I can.
osteoporosis?
Yes.
Okay, so obviously the one that we're going to talk about a little bit more is staying physically active and choosing weight bearing and resistance exercises. Um, Foods that support bone health, getting enough vitamin D and calcium. You can see that I added that because the graphic was not satisfactory to me.
Mhm.
Those are all things that we're going to belabor a little bit, but something that people don't realize is that maintaining a healthy body weight, being underweight, having an overall BMI of less than 19 in on average as an adult, or kind of the number that I throw out for a lot of people because this is also a separate risk factor is having a body weight of 127 pounds or less on average as an adult. Those two things are independent risk factors. Additionally, having a high BMI and a poor diet are also going to kind of contribute to having a unhealthy bone mass. So maintaining a healthy, medium body weight is really going to be where we want to be. Additionally, tobacco use, smoking, vaping, all of those things really leach bone aggressively. So does too much alcohol, so does too much caffeine, so does too much sugar. So all of those things that we worry about kind of leaching, I think are really important to point out because you can do all the physical activity, you can get